Hi, everyone. My name is Ian Solsky. I'm a surgical oncologist at the University of Tennessee Health Science Center. I treat patients with GI, skin, and soft tissue cancers, but my interest and expertise is in the management of patients with peritoneal surface malignancies, which is what we'll be discussing today. I want to thank the organizers of this conference for the invitation to speak. This talk is designed to provide you with a high-level introduction to cytoreductive surgery and hyperthermic intraperitoneal chemotherapy, or HIPEC for short. By the end of this talk, you should have an understanding of why we perform this procedure, how we select patients, and why it is still controversial in certain settings. I'll also briefly highlight a few management considerations for these patients to emphasize the necessity of a team-based approach. The peritoneum is a serous membrane that lines the abdominal cavity and many of the organs in the abdomen. When we talk about peritoneal surface malignancies, we are talking about a group of cancers that can involve this lining. Some cancers spread to the peritoneum from a different location, such as colon cancer, and others originate from the peritoneum itself, such as peritoneal mesothelioma. Sometimes the disease presents in a nonspecific fashion with vague abdominal pain, weight loss, or other symptoms. Other times, the presentation can be dramatic, in which patients present with significant abdominal distension, the so-called jelly belly, or in medical terms, pseudomyxoma peritonei, which is a process in which the cancer cells in the peritoneal lining release mucinous ascites that fills the abdomen. There are unfortunately many cancers that can spread to the peritoneum with varying frequencies. Patients with peritoneal disease from an appendiceal cancer or mesothelioma are essentially 1 in a million. These are very rare diseases. However, studies suggest that peritoneal disease may be found in 60 to 75% of patients with ovarian cancers, 20 to 25% of patients with colorectal cancer, and 20 to 45% of patients with gastric cancers. There are several other cancers that also spread to the peritoneal lining, such as pancreas and gallbladder cancer. Historically, patients who have developed peritoneal metastases have had extremely poor outcomes, with survival usually under 1 year, and sometimes not more than a few months. Cytoreductive surgery in HIPEC has arisen from a desire to improve upon these poor outcomes. So what is cytoreductive surgery in HIPEC? The way I describe it to many of my patients is to say that it's a search and destroy mission. The goal is to systematically evaluate the abdominal cavity for any evidence of visible disease and then to remove it. Disease that is along the peritoneal lining in the abdomen, pelvis, or the diaphragms must be stripped away. Disease that is involving intra-abdominal organs also must be removed. Thus, patients sometimes need multiple organs removed as part of this procedure, which may include removal of the spleen, gallbladder, uterus or ovaries, stomach, small bowel, or colon. Once all visible disease is removed, we then perform HIPEC, or hyperthermic intraperitoneal chemotherapy, which means that we perfuse the abdomen with heated chemotherapy to try to eradicate any microscopic residual disease that may remain. A benefit of HIPEC is that it can be delivered directly to the site of disease in the abdomen in high concentrations that could not be given intravenously without significant side effects. Furthermore, the use of hyperthermia was found to be synergistic by increasing the chemo's ability to penetrate tumor. Although the use of cytoreductive surgery can be traced back to the 1930s, when it was first being employed for ovarian cancer, it was not until the late 1970s that a HIPEC delivery system was designed, and the practice of combining cytoreductive surgery and HIPEC was truly spearheaded by a surgeon, Dr. Sugarbaker, in the 1980s. Over time, there has been accumulating evidence to suggest that cytoreductive surgery and HIPEC may improve patient outcomes. For example, in patients with peritoneal disease from colorectal cancer, supportive care is associated with a median survival of about 5 months. With modern chemotherapy, median survival can be stretched to approximately 24 months, and with the surgical approach, survival has been reported to be over 40 months. Encouraging results have also been seen for select patients with ovarian cancer and gastric cancer. And for peritoneal mesothelioma and low-grade appendiceal mucinous neoplasms, also called lamins, cytoreductive surgery and HIPEC is the standard of care, with survival rates being reported as high as 3 to 6 years and over 10 years, respectively. Despite these encouraging outcomes, what should be evident is that this is a very aggressive approach. The complication rates can be as high as 40%. Now, half of these are minor complications, things like wound infections or ileus, but the other half can be significant, like anastomotic leaks, pulmonary embolisms, and the like. The mortality rate of this procedure is roughly 2%. It's important to note that these risks are not far off from those that are seen in other major oncologic procedures, such as Whipple's and esophagectomies. Nonetheless, there are real risks associated with this procedure, and therefore patient selection is key, which is what we'll now discuss. Although many different types of cancer spread to the peritoneal lining, only certain types are eligible for cytoreductive surgery and HIPEC. Currently, this procedure is primarily only offered to select patients with appendix cancer, peritoneal mesothelioma, ovarian cancer, colorectal cancer, and gastric cancer. Patients with other types of cancer, such as pancreas, generally will not be candidates. The reasoning is this: if we are going to offer patients such an aggressive procedure, we need to have a reasonable degree of confidence that their cancer is confined and will stay confined to the abdominal cavity. No matter how many intra-abdominal organs we remove, it won't have any oncologic benefit to patients who have a cancer type that has a propensity to spread distantly to the chest or elsewhere. Therefore, highly aggressive tumors with a propensity to spread distantly, such as pancreatic cancer, will not be managed most appropriately with this procedure, and these patients will be better off with other treatments like chemotherapy. The next thing to consider is the extent of disease and whether it can entirely be removed. An ideal cytoreduction is defined as either no visible tumor or the presence of tumor nodules no larger than 2.5 millimeters. Leaving nodules of this size is acceptable because HIPEC is considered to still be effective for treating nodules of this size. Survival outcomes are better for patients when an ideal resection can be achieved, but our ability to achieve an ideal cytoreduction is dependent upon how much disease the patient actually has. So the way in which the disease burden is communicated is through the calculation of the peritoneal carcinomatosis index, or PCI. PCI is a scoring system ranging from 0 to 39, in which the abdomen is divided into 13 regions, which are given a score of 0 to 3 based upon the extent of disease. The PCI can be quantified preoperatively by imaging studies such as CT scans, or more accurately via diagnostic laparoscopy, in which a camera is surgically placed into the abdomen. Trying to estimate a patient's PCI score before surgery is important to determining whether an ideal cytoreduction can be achieved, and thus whether surgery should be offered. Together with the extent of disease, the tumor type will be considered. For example, patients with low-grade appendiceal mucinous neoplasms may be candidates for surgery even with the maximum PCI score of 39, because their tumors are slow growing, remain within the abdomen, and they're only effectively treated by surgery. By contrast, patients with gastric cancer are generally only candidates if they have a low PCI score of around 7 or less, because higher scores are suggestive of more aggressive tumor biology. Equally important to the extent of disease is its location. Extensive disease isolated to the small bowel or the porta hepatis, where critical structures to the liver run, may preclude the ability to achieve a complete cytoreduction. Furthermore, the presence of metastatic disease to the liver or lung, in addition to the peritoneum, should give a surgeon pause about undertaking these major operations. Patient factors must also be considered. Like any major oncologic procedure, it's essential to make sure that the patient is fit for surgery. Age in and of itself should not exclude patients, but we must carefully consider their fitness, comorbidities, and prior treatments. Additionally, it's important for these patients to be motivated, to have a good support system, and to have realistic expectations for what can be achieved with surgery. Now, we don't have time to get into all of the controversies and exciting areas of investigation in this field, but I do want to briefly touch upon the main controversy in the context of colorectal cancer. The main controversy is, does HIPEC actually benefit patients? And when I say HIPEC, I'm not using that term to include cytoreductive surgery. I'm talking specifically about the perfusion of the abdomen with heated chemotherapy. Although informally, we often use the term HIPEC to refer to both cytoreductive surgery and HIPEC, and it's important in your mind to decouple these terms as separate procedures, as will be explained. Now, the one study which brought a lot of attention to the question of HIPEC's utility was the French PRODIGE 7 study. This multi-center trial published in 2021 randomized 265 patients with colorectal peritoneal mets to a group undergoing cytoreductive surgery without HIPEC and to another group undergoing cytoreductive surgery with HIPEC. In this study, the major finding was that there was no difference in overall survival or rates of recurrence between groups. However, on a subgroup analysis, patients with an intermediate volume of disease did benefit from the addition of HIPEC. The results of the study have become a flashpoint. Some have used this data to declare that HIPEC is an ineffective treatment that adds risk without clear benefit. However, those who support HIPEC point to the significant limitations of the study. For one, the specific HIPEC perfusion protocol, which used oxaliplatin for 30 minutes, has been strongly criticized as most centers perfuse with a different drug and for a longer time. Most use mitomycin C for 90 to 120 minutes, which is what I do. Furthermore, the study did find some signal of a survival benefit in a select subgroup with moderate disease, though the reasons for this are not entirely clear. Ultimately, these results only further fueled the flames of controversy about HIPEC. However, what is perhaps most significant about the study is the finding that there was a rather remarkable median overall survival of over 40 months for both groups in the study who had undergone cytoreductive surgery with or without HIPEC. This 40-month survival had not been rivaled by any other therapeutic intervention. Therefore, this study clearly showed that despite some legitimate concerns about the utility of HIPEC, it unequivocally established cytoreductive surgery combined with systemic therapy as a standard of care for colorectal cancer peritoneal metastasis. The reason why I wanted to emphasize these findings is to make the point that I think surgery or cytoreduction is here to stay as a treatment for select peritoneal surface malignancies, including colon cancer. Whether HIPEC will also play a role in the future and in what circumstances is still to be determined. There are many important questions regarding the use of HIPEC that must be answered, some of which are listed here, and there are ongoing studies to answer these questions. Time will tell, but I believe that patients are going to best be managed by multimodal treatment strategies, which will include chemo, surgery, and possibly HIPEC. Therefore, even now as data is accumulating, it is crucial for these patients to be managed from the start by multidisciplinary teams experienced in the management of these patients. These patients are complex and the decisions being made can be nuanced. So if there's one takeaway from this talk, it is to make sure that these patients are not being managed in isolation, but are being managed by a team that includes medical oncologists, surgeons, radiation oncologists, radiologists, pathologists, and of course, nurses and APPs. To further emphasize this point, I want to finish my talk by briefly going over some key considerations in the management of these patients throughout their treatment course to illustrate the many team members that are needed to optimally manage these patients. Often, the initial workup of these patients is being performed by primary care providers who are involving radiology and gastroenterology for a variety of imaging studies or endoscopic procedures. However, and as mentioned, the diagnosis is not always straightforward. For example, sometimes female patients will present with a pelvic mass and concern for peritoneal disease, but it won't be clear if this is related to a gastrointestinal or gynecologic cancer. In these cases, it may be prudent to involve both surgical and gynecologic oncology. There have been cases where I have jointly performed the diagnostic laparoscopy with the gyn-onc team so that we can both bring our respective expertise to the operating room to try to obtain the right diagnosis. To obtain that diagnosis, tissue is always needed, and a biopsy can be performed either by surgeons if a diagnostic laparoscopy is being performed or by interventional radiology. It is key that biopsy specimens are reviewed by experienced pathologists, especially for the appendiceal tumors, which vary greatly in terms of biologic behavior, and this has real implications for management. Patients with low-grade appendiceal mucinous neoplasms will be best managed by an upfront surgical approach, but patients with higher-grade adenocarcinomas will benefit from chemotherapy first. Therefore, we must get the diagnosis right. Once the diagnosis is obtained, these patients should be discussed in a multidisciplinary fashion with surgeons, medical oncologists, and others to make sure that there is agreement about the treatment plan. Additionally, once patients are given a diagnosis and plan, it is important that these patients also have access to additional services that may be needed to support them physically, emotionally, and socially throughout their treatment course. Performing so-called rehabilitation for these patients to optimize them for treatments may require assistance from physical therapists, psychiatrists, or psychologists, social workers, nutritionists, and others. Now, for patients who do proceed on with HIPEC, careful coordination is needed with the pharmacy and perfusion teams to ensure safe delivery of intraperitoneal chemotherapy. Anesthesia and pain specialists should be involved preoperatively to consider performing blocks or placing epidurals to assist with postoperative pain. If extensive pelvic surgery is expected, we sometimes ask urology or the gyn-onc team to place ureteral stents before surgery. The nursing staff is critical not only for facilitating events in the OR, but for also helping to communicate with family throughout this long procedure. Postoperatively, strong critical care, GI, and IR teams are needed to help rescue these patients if they develop any complications. And of course, physical therapy, social work, and nutrition are all important to ensuring that these patients recover appropriately. After leaving the hospital, these patients must be closely followed. Surgical pathology must be carefully reviewed and again discussed in a multidisciplinary fashion in case the patient needs any additional treatments like adjuvant chemotherapy. These patients must also undergo surveillance with physical exams, blood work, and imaging to monitor for recurrent or progressive disease. Studies have shown that these patients' quality of life may not return to baseline for up to 6 months after surgery, and this may involve aspects of their physical, emotional, or social functioning. Therefore, the same services that some patients need preoperatively to be optimized for surgery may also be needed postoperatively to help them recover. And of course, there are unfortunately limits to what our treatments can achieve for some of our patients. And in these cases, palliative care is extremely helpful for supporting our patients and their families. In conclusion, cytoreductive surgery in a HIPEC is an effective treatment option for carefully selected patients with peritoneal surface malignancies that may improve patient outcomes. Patient selection is key, and these complex patients must be discussed in a multidisciplinary setting for optimal care. There is still much for us to learn about the role of cytoreductive surgery and especially HIPEC, but there's encouraging data that currently exists to support its use for many patients. Ultimately, the care of these patients requires a team, and that includes many individuals like those in the audience today. So thank you all for everything that you do for our cancer patients, and thank you for your attention.